as we know, historically, one of the issues that has led to the guidelines had been to this enormous surge in the number of prescriptions in the general pediatric and the general child and adolescent population, especially in the number of antipsychotics that were being prescribed to kids over the years, as well as the multiple number of medications that were being prescribed for each child. And over the years then, we focused on appropriate prescribing guidelines as a vehicle for a practitioner to look at and know how to tier in, or when it's appropriate to move from monotherapy to combination therapy, et cetera, to avoid some of those pitfalls of getting into 3, 4, 5 medications, 6, 7, much higher, way back for many years. And although initially the impetus was cost and utilization, it's really been driven by the effort to look at quality. And then the quality, obviously, if you have good quality, then your costs are what they are, rather than just looking at having less number of expensive medications being prescribed. And so what we found over the last couple of years that obviously the concept of de-prescribing has become more and more of an issue. Say, okay, now we're getting into understanding what appropriate medication treatment options are when you initiate treatment with someone who is seeing you either for the first or second time, but that in practice, we all see these kids that are complicated and already come to us with all these medications. Then they're coming to you on 4 medications, 3 medications, 2 medications. And then how do you address that? Because that may not necessarily fit neatly in our guidelines, because they're coming to you already treated versus you're initiating treatment de novo on that child. And there is, again, a burgeoning literature on this, but there's also a paucity of literature on the neurodevelopmental disorder population. There is an increasing literature on the elderly especially, and then there's a small but growing literature in the general child and adolescent population as well. And so this is an effort to kind of just review a little bit, then provide some kind of framework for that decision making, or at least provide a perspective on this issue, which is something that we encounter all the time. So one of the things that we know is that de-prescribing does not equal stopping medications. So that's a real important point, because de-prescribing means trying to identify the MED, the minimum effective dose for each medication, and the appropriate number and or combination of medications necessary to manage both the symptoms and any functional impairment that may exist, right? And the goal is to try to find some systematic or structured way of how to address that. And again, looking at when we've all seen individuals, or someone encounters an individual that's already on multiple medications. And that some individuals have talked, instead of de-prescribing, which tends to have a more negative connotation, to look at medication optimization as the term, right? Because what you're trying to do is really look at what the most appropriate medication treatment regimen is. And if that means discontinuing some medications, that's great, but not to focus on removing medications, because as you can see, there's a tendency to equate it with stopping meds, of which this is some of it, right? And we also know that it's a really complicated process. We've all done this, and we know that discontinuing medications can bring complications, and that you'll see as we go, you have to prepare and expect for some recurrence or some worsening of symptoms, because that is not unusual and not infrequent, but that you want to be realistic about it. Because I used to say it will happen, but I've tuned that back to say it probably will or may happen, and so be prepared for it. Don't be surprised by it, as well as informing, as you'll see, the caretakers, the families about this happening, and not saying, oh my gosh, this happened and therefore this has failed and we shouldn't be doing that, right? And certainly it's not straightforward, right? So you can see individuals are sometimes, so a practitioner receives a child who's been on medications for years. They've been on multiple medications for years, and these meds have not, and the regimen hasn't changed. So someone may be a little reluctant to make changes because they've been on these medications for such a long time. And knowing our system here in the state of Florida, a lot of times we don't have access to the appropriate information to make informed decision making, so that creates another level of difficulty or another challenge, saying, gosh, this child's been on this medication all this time and I'm seeing you for the first visit and you've come 20 minutes late for this initial evaluations and I don't have any previous records, and you're presenting with all these symptoms and therefore an expectation of something being done. And that initial discussion of even this, of introducing the fact of maybe reducing a medication sometimes isn't well received because it's perceived as not meeting the initial goal of producing a change. My child's not sleeping, or the child's agitated, or the child's aggressive, or et cetera. And so therefore, it really creates a lot of issues for the prescriber and for the clinician, right? As I said, there's been an emerging literature on this, even in the ID population. This is in adults, and this is in the ASD populations, or ID population, where they talk about what are some of the factors that are predictor of worse outcomes, rather than factors that could predict more positive outcomes. Then obviously it includes things that we kind of know, right? That if you have a lot of problem symptoms, that's going to potentially lead to worse outcomes if you're looking at changing medications, right? Or if you're on higher baseline antipsychotic dose as well, right? Or if your baseline issues or psychopathology prior to initiating treatments for more severe, that's another tendency to predict more difficulties in trying to make changes to these complicated regimens. They call it unsuccessful attempts, but it really is a challenge, right? So the literature is emerging, and most of it's abroad, right? But we're trying, right? So what are the factors that could lead to these difficulties, let's say, if a child's on antipsychotics specifically? Well, one is interpretation. So if the child's on an antipsychotic and a stimulant, an antidepressant, an alpha-2 agonist, something else, then you start decreasing the antipsychotic. One of the factors that we think is how the caretakers or the individuals involved attribute the symptoms. So, oh yes, they're more agitated because you decrease the antipsychotic. Now versus they're more agitated, but let's see, right? Let's see what that could be from or not. And there's a tendency to really, at times, overascribe. Especially, like I say, if you're not there at 11 o'clock at night with that child, or in the group home, and the staff is saying, but wait, we need that child to be in bed, or we need that child to follow what needs to be done at noon on Sunday, etc. Some of the other issues is that sometimes we make decisions to either decrease or remove them, but actually those kids may actually benefit, or it is indicated to have that treatment there. And again, part of this is this whole issue of assessment and getting good data up front and information historically and seeing about indications, et cetera, when it's complicated by medications and history and social and environmental issue. And then discontinuation or withdrawal symptoms that are really medication related, but then sometimes can be misinterpreted as a worsening of the actual target symptoms. akathisia, agitation, anything like that, right? Or even sleep changes, et cetera. And it's a really complicated issue of trying to assess this, as you know, within the context of this population, whether it's use of language skills on self-report, whether it's good, accurate reporting by a parent, caretaker, staff in certain agencies, et cetera. So a lot of caution in what some of the issues that may lead to difficulties or failure in making these adjustments. And so clinically, when this arises, you have to make decisions like, do I continue the meds? Do I reduce them or do we stop them? Do we assess what the harm is, the potential harm of these changes? And what am I going to be monitoring, right? Those are for you that are very visual, right? We want to have, and so it involves these clusters of areas such as, gosh, is there any existing evidence on de-prescribing these medications in this population? And as I preface it, there's some, but very minimal, right? So you extrapolate from other populations. How do I get the caretakers, the families, or the actual individuals involved in this process, right, if you can? What are the potential harms of either continuing or discontinuing the medications, right? You'll see me do a lot of this, right? And then what are the potential costs with this de-prescribing, right? Keeping going. On the other hand is, well, what are the factors that may even justify continuing using it, or not even changing it, or continuing the medication, or even increasing it because maybe it's indicated, but it's being utilized in a sub-threshold fashion, right? You always engage the family, right, and what their values are. We've all encountered families who do not want their kids treated, for example, with stimulants, even though you may believe it's the medication that's indicated or should be continued, and they come in and say, we don't want this, or we don't want Prozac, we don't want Prozac. I've got a cousin, kind of, but we all know that we have to respect families' values and what they believe about the medications, and then incorporate that into the informed decision making and recommendations, right? Then you get into your monitoring plan and say, what am I going to be looking at? Then how are we going to monitor it? What's the frequency? How are we going to monitor it, et cetera? And then how do I, if I decide to decrease or taper a medication, how do I actually do it? So one example is, we've had individuals say, oh, it's fluoxetine, we're going to go and then start decreasing it every other day, because that's the way it should be tapered. And so we've gone and reviewed the literature, and there's actually no literature on that. There's a lot of folklore, there's a lot of common sense to it, and when you look at the pharmacokinetics of it, the half-life, but there's actually no literature that there's either in any population that's an appropriate way of doing it. Even at one point a few years ago, we contacted Eli Lilly to see if they had any information on that. But does it make sense on some level? Potentially, but you decide, right? And that's what we talked about, some of the levels of evidence and how to make these things. And then how to manage any recurring symptoms if they do arise. So, and that's why sometimes in certain populations you'll find that tapering is better one way or another. Well, same thing with clonidine, right? Oh, you're on 0.2 TID. Oh, we're just going to stop clonidine. Versus we're going to look at reducing it or tapering it another way. So some medications you decide on just discontinuing, and others you taper, and others you taper certain ways, right? And then if there's not a lot of evidence on how to taper it, then how do you incorporate that into what is doable with the family and the caretakers and what they prefer? Right, because you can have this elegant plan in your minds, but if in the implementation side of it, it's really complicated, that we're going to do this 4 times a day, every 8 hours. I go, really? Every 8 hours? While awake or when I'm sleeping, or what am I going to do? But how does that translate into the real world, right? So and some of this came from Dr. Baker's talk. Some of this, we thank Dr. Megan Baker for some of this.
Yeah, and it's the new guidelines.
It's in some of the,
There.
yes, but this is an augmentation. So this isn't just some of that. So this was this is our 2.0 version. But you'll see some of these are areas that we did get from her. So obviously one needs to begin with an assessment, right? And that's where you get into the dangers of, okay, let me look at what's been happening, including getting the past medication history. And we all, and individuals feel pressured on that first visit. We got to do something. We got to do something, depending on the acuity, which is not unusual. But how do you make decisions when you don't have the information you think is appropriate or needed to make informed decisions? As always, we recommend using standardized scales as a way of not only establishing the baseline when you first see someone, but also monitoring changes. And these scales, the rating scales will be different depending on your target area, what you're targeting, the cluster of issues or problems. There should always be as comprehensive as possible, not only medication reconciliation, but a comprehensive list of what the individual's taking, including over-the-counter products, including complementary and alternative medications, etc. And attempt to determine what they're supposed to be targeting. And if you ask that to parents, well, what's that supposed to do? They go, yeah, that's supposed to sleep. It's supposed to sleep. Okay, so somebody's prescribing the quetiapine for sleep, right? Okay. Oh, yeah, that's supposed to have them be, I don't know, follow my directions. I go, oh, okay, that's a yes, mom, okay. I got to remember that one, right? So, but you try to at least determine from the caretakers, or obviously from any records that you have available, what they're being prescribed or what they're supposed to be doing, at least, right? Obviously, you've heard it, and this is like the proverbial 3 touches. For the 3rd time, get the records, get the records, get the records, which we know all those challenges, right? And then once you get that information, you got to go, okay, let me try to assess when this was started and what, if any, effects or benefits, or was it helping for what it was supposed to help, right? And that, and that's not only based on the information of records, but also on self-report from the youth, if they can, or parents or any other individuals involved, where we're kind of assessing, yes, since they started this medication, the child has displayed these changes, and we think it's related to this, and so that you can at least, again, integrate that in your decision making, right? You want to look at overall side effects, and not just from the additive effects of each other, but look at all side effects or any potential negative effects of a medication or a combination of medications. In your minds, you want to be able to be aware of what the evidence is for continuation of that treatment once you've gotten that information, the justification of that treatment, both taking into account the potential treatment course and or the natural course of the presentation of those symptoms in the child. That whether you add medicines or not, will some of that be like a wave and just improve naturally, or and then we misattribute the improvement or changes to the medications, or not, right? And as always, you can't go wrong with developing a comprehensive plan, right? I know for you all it's so basic, but yes, develop your comprehensive plan, including looking at multiple domains of functioning: school, home, social, office. You don't want anybody tearing up your office, right, and things like that. So that's it. And then you go, how do you start? So at one point, a few years ago, I was going, I'm going to start with the medication that was added last. I'm not sure what any of these indications are. And then I started thinking, but what do I base that on? Just because it was the last one? Because I'm not sure of these other two either, but they weren't started last. And so I said, wait, I have to really look at this a little bit more comprehensively rather than chronologically. So you start with, if there's one medication without any clear indication at all, maybe that's one to start. Remember, this is a framework, right? So that we can at least make some decisions in some way that hopefully makes sense and helps the individual, right? And even if there isn't that absence of an indication, you start maybe one that isn't so clear. Remember, it's a spectrum, right? So, or you start one where there's the least evidence of efficacy, or which it seemed to be so out of left field, right? We're going to use this antipsychotic for, attentional issues. And then you go on and say, let me look at this medication, and we've really got enough history to say that it really doesn't seem to have improved, it has not improved the symptoms, or those initial cluster of symptoms have improved, have really stabilized, so therefore it really did seem to benefit it, and maybe it's time evaluate whether it's time to then discontinue it, because these target symptoms, there's been a period of prolonged stability of these symptoms, right? And then whether they're prescribed out of whatever guidelines that do exist on it, whether it's a dosing guidelines or others. Be careful about a prescribing cascade, right? About you start making changes, and then there are new symptoms or changes in symptoms, and then those get evaluated, and then another change is made, and that change may or may not complicate things, and therefore you make other changes, and that if that first assessment maybe was based on something that's misinterpreted, it leads to a whole cascade of things and saying, oh my gosh, you're agitated, we need to increase your this, and then you're not sleeping, and then we need to add this, and it's really based on maybe on a reassessment of what your initial change or your initial baseline was, and not leading to this whole cascade of things. And again, not easy, but an important point to mention. Again, the caretakers and family need to be involved when you develop your plan, right, of what you've decided. Either you're going to decrease or you're going to stop. They need to be involved, and they need to be informed, and they need to be aware of the potential benefits, your goals, but also any of the potential risks and negative issues. Really look at these, consider or appraise your level of risk, so that if you're projecting any potential risk of high risk behaviors or more dangerous behaviors, you should really have some kind of safety plan or crisis plan. That has happened as well. When we've started looking at meds, kids can sometimes get worse, and these serious behaviors not necessarily emerge, but worsen, and therefore you really should have a contingency or a plan for that before that happens, right? Basic prescribing, there's never a perfect time. Anybody who's looking for a perfect time, boy, God bless you, but you're never going to find that. So you look for the better times, avoid times of high stress, transitions, potential crises. Like I always joke that we've had patients say, oh, and we're going to Europe for 3 months and we're going to stop this medication. And what? And you're just leaving and you're going, and it's like, maybe that's not the best time, right? Then the true kind of scientific method, if you will, make one change at a time, change one variable at a time, one medication at a time, lest you lead yourself into getting into potential complications and interpreting what changes follow those medication changes. Then, as we've said before, try to use either symptom or other rating scales to monitor what is happening in a more standardized, objective way as well. Always implement psychosocial services without a doubt. Determine how you're going to monitor it, right? How you're going to monitor it, determine what you're going to look for, how frequently you need to monitor depending on the individual characteristics of that patient and the needs, including the psychosocial supports, the severity of the symptoms, your risk assessment, etc. And then obviously they have some contingencies if symptoms or problems emerge. So if an individual is only 1 week at 2 half days at a certain agency or clinic, and this is somewhat of a high-risk individual, have some other contingencies available for that monitoring and or questions if those symptoms recur. So I usually put this because this really is a balancing act, right? And you look how serious they are in focus. It really is an energy-draining process, right? See, this boy's smiling, but that dad is not smiling so much. But a little bit like a Harpo Marx kind of haircut there. But it really is a balancing act with this, right? You heard me say that. And that's really what it looks in a lot of ways. We don't want to leave the moms out. See, the moms are frequently the ones that have to do a lot of this caretaking and have to follow through of what we do. And in the academic or in some kind of intellectual world, it could look like this, that I am doing this balancing act over this beautiful valley and all these wonderful things are happening. But in reality, it could be this, right? That we're doing this balancing act, but really there's the potential for all of this negative stuff to happen and a lot of real serious things or potential for things to get worse, right? So again, this should not be a surprise if symptoms recur, right? And that be careful of how you interpret if there are any changes afterwards. And that try to determine or assess if these are just fluctuations in the course of what you would expect. You remember when we talk about ASD, we talk about atypical, right? And so sometimes if you look at the natural course, you'll say, gosh, these things come and go, whether historically we've intervened with this and this and this, these behaviors are going to improve. Whether we make this change or that change, can we proverbially write it out? Can we provide other services? Can we ensure safety? Can we do this and this and this to see if those behaviors will improve? Or if they're related to a reduction in medications, whether those symptoms will naturally, for example, a discontinuation symptom, whether they will improve with a few more days naturally without having to make any other changes, and hopefully, again, be able to manage that symptomatically or otherwise until that happens. If there are symptoms, obviously you can look at psychosocial variables, the social determinants of health, environmental variables to see the impact of that and the interaction of that at the time. Or look at the need of increasing any non-pharmacological supports or interventions to see if that helps as well. Now again, we all kind of do this, and we all know that we're in a somewhat resource-limited environment, especially within our Medicaid population and in certain parts of the state, but that would be the ideal. And if that could be planned for before it happens, or if you can quote-unquote predict it or project it, then that would certainly be a better plan than waiting to react or respond to a little bit more of a crisis, right? And sometimes that takes work with the caretakers of maybe finding different ways rather than say, always looking directly to the meds that, oh, these are here, let's look, he needs more pills, the individual needs more pills or needs more meds, versus looking for alternative ways of managing that. As you're going through, obviously you're updating your assessment, even possibly updating your differential diagnosis and determining if some of these were, I don't know, artificial comorbidities really initially and not true comorbidities or not, and therefore updating your plan as you're proceeding, right? In the event that you do determine that that individual did benefit or would continue benefit from that treatment, you want to reinitiate medications at the least effective dose. Hopefully you've obtained that from some of your history and your observations, etc. And then after you've restabilized that individual, you would consider if and then when would be another opportunity, or how long before you look at another attempt at reduction and or discontinuation. Gee, we've tried this, but and we know that from antidepressants, we know that treatment of other disorders, etc. But consider that, please, right? And then if you do need to resume medications, you may have a decision and say, gosh, you've been on this the longest time, and these symptoms are now reemerged, or we need to retreat it. Do we reinitiate treatment with what you've been maintained on, or do we initiate treatment with a different medication at this point in time because it seems to be more appropriate? I emphasize the word seems, right? Because you use your best judgment at that moment. You're smiling because this is all real world stuff, right? You go like, gosh. Again, this is always a balance between the risks and the benefits, right? So always start with being clear of any reasons for deprescribing. Always start with that, right? And again, so this is a little different than I try to at least provide some cheat sheet kind of way of summarizing this, if you will. You begin with your assessment, right? Taking into account, obviously, the medication history. You consider all those factors that may affect whether the benefits or the risks of changing those medications, and then document it clearly. We know how important that is because we know over time, especially when you get the records from before and you go, what was the justification for this medication being started? It's not clear. So the real emphasis is to say, we're going to begin this because of this, and we expect this, and we're going to, and et cetera. So please, there's a big emphasis on that, right? Take into account the families and or the individuals' values, concerns, expectations when you start, right? You communicate all these things to other personnel and other staff that may be involved. If they're in a group home, you want to make sure everyone's clear because those expectations want to align with what you're expecting is going to happen. If they're expecting something more proximal, more immediate, and you're explaining that this is a little bit more of a longer path, then that there isn't going to be that immediate change. They better be aligned or else there's going to be issues, as we know. And adhere to both not only evidence-based guidelines, but any formularies if appropriate, right? Because obviously we want to translate these things into real-world kind of decision-making, right? And even if there are guidelines or formularies and they haven't been developed for this population of individuals, you really want to have caution in saying, gosh, if this is on the formulary, but I really think it's this, do I really advocate for this one, even though this is what's on the formulary? And people have to make decisions about proceeding that way, right? After you identify the medications that could be reduced, I should have put reduced first, and or discontinued, you want to make sure that they're all going to be safe in this population, right? Hopefully cost effective. In the appropriate form that that individual can ingest in their body, and hopefully effective for whatever. So which medications you're going to start with? Well, if there's one with absolute, I hate to use absolute terms, but absolutely and not a clear indication, you probably want to start with that one. If after further information it seems to be that the symptoms for which it's being prescribed are unclear, it may not be so absolutely clear, but they're not really clear, then you move down and say, maybe I'll begin with this one. And then if not, and again, this isn't necessarily a hierarchy, but it's at least some attempt at trying to give some framework. And then maybe if you see one where there's the least level of efficacy, that if you're using this medication that seems to be very poorly justified for these symptoms, maybe I'm going to start with this. Even though in the chart it may say, we're using it for this. This medication is we're utilizing to treat this for this. Obviously the monitoring, right, to look at, again, always have a plan, right? You saw it, one change at a time. Look at the timing of these changing. And this one I inserted, but this is a big issue, right? One needs to be self-aware enough that if you're going to embark on this treatment journey, you need to be aware of either the limits of your knowledge and skill, and if you want to embark on that, or whether you want to be cautious and look at some other options instead of embarking on that, lest you get into further complications. And that could be a tough one, right? Because there could be a lot of external pressures, whether it's from the family or from the agency or somewhere else. And so I did want to include that in there, so that when to say this goes beyond the scope of what I blank, blank, blank versus let's start this and this and this.